Yeah. So we'll start with shoulder pain. So Bushra, if you can say a couple of differentials for shoulder pain, if someone's presenting with shoulder pain, what will be your top differentials?
It could be the frozen shoulder,
Okay.
or it could be the trauma,
Yeah.
or then it could be the referred pain as well of any like tumor, or it could be the painful arc syndrome, or acromion. Acromion. Just forgot the word. Yeah, that was.
Bursitis, your
Yeah, bursitis. Yeah.
yeah. Anything else that you can remember, or anyone else also can participate?
It can rotator cuff tear.
Yeah.
Yeah.
And anything else she missed? So
No.
I also want you guys to do some brainstorming so that
Osteoarthritis and tendinitis.
Polymyalgia rheumatica.
Yeah, tendinitis only. Yeah, tendinitis can be one of the causes as well. Yeah, biceps tendinitis. Yeah, polymyalgia rheumatica. Very good, very important differentials. And what else?
Polymyositis.
Yeah, it can be one as well. Yeah,
it can be shoulder dislocation.
Yeah, shoulder dislocation is one.
It can also be biceps.
Or then it could be the referred pain as well of any like tumor, or it could be the painful arc syndrome, or acromion. Acromion. Just forgot the word. Yeah, that was.
Bursitis, your.
Yeah, bursitis. Yeah.
Yeah. Anything else that you can remember? Or anyone else also can participate.
It can rotator cuff tear.
Yeah.
Yeah.
And anything else she missed? So I also want you guys to do some brainstorming so that
osteoarthritis and tendinitis.
Polymyalgia rheumatica.
Yeah, tendinitis only. Yeah, tendinitis can be one of the causes as well. Yeah, biceps tendinitis. Yeah. Yeah, polymyalgia rheumatica, very good, very important differentials. And what else?
Polymyositis.
Yeah, it can be one as well. Yeah.
It can be shoulder dislocation.
Yeah, shoulder dislocation is one.
It can also be biceps tendon rupture.
Yeah, tendon rupture as well. Yeah, that comes from trauma. So so many differentials we have, but the thing is, when you are approaching a case, you should have these differentials in order, right? So that you are not missing key differentials, because shoulder pain can have lots of differentials. So what we need to have in our mind is a structure, is a pattern that we won't be missing key differentials. Okay, so first I'll go through the differentials first. I'll show you the differentials. So and then I'll give you a technique to remember so that it's easy for you guys. So if you see someone mentioned traumatic, so under traumatic, if you can think what are the things. So rotator cuff tear, someone mentioned fracture and shoulder dislocation. So if you remember trauma and asking the patient about trauma, so it covers most of it, right? So if the patients have, so you don't need to ask separately, oh, did you have this trauma to have dislocation or fracture? So you can just ask about, did you have any trauma recently? So that covers all the differentials from here, right? And then we have degenerative ones. So these are mostly age related or from chronic diseases. So you have rotator cuff tendinopathy from repetitive use, and you have osteoarthritis, that's a age related change. Adhesive capsulitis, that's we see mostly in diabetic patients. And then you come to inflammatory. So we have different type of inflammatory arthritis. So rheumatoid arthritis is very common, and though it's not very common for shoulder joints, but you can still have shoulder joint presentation as well with rheumatoid arthritis. Then you have polymyalgia rheumatica, someone mentioned myositis. So dermatomyositis involve the proximal muscles, very important. And then you have reactive and psoriatic arthritis. And then we have infectious causes. I think someone mentioned this as well. So it can have osteomyelitis, though very rare. Someone mentioned bursitis. Septic arthritis is also common. And then we have the neurological. So it's cervical radiculopathy. So it will be starting from the neck, then it will radiate to the shoulder. Okay. And then we have an interesting one here, fibromyalgia. So these are like pain syndromes. Sometimes we don't exactly have the etiology, but the patient may present with, pain, and they can also tell you that they are having shoulder pain. Then referred pain, Bushra I think mentioned about referred pain. So it can come from MI, so it's very common, we all know. Sometimes gallbladder can have pain in the tip of the shoulder as well, and there are lung pathologies, but these are not very common. And then again, we have malignancy, which we all know, like for everything happening in our body, malignancy can be one of the etiology, right? And a very interesting one, this is the medication statin. Sometimes we have statin induced, because we know the side effect of statin, it can do muscle damages, so we can have muscle pain, and as shoulder and this area has more prominent muscle, you can have statin induced myopathy as well. Okay. And another thing I think we are not seeing here, that's like thyroid. So sometimes thyroid has myopathy, so even that can cause shoulder pain, but that will be symmetrical on both the sides. So far I think we are clear about the differentials, right? So if you see here, the differentials are like, there are a lot of things to remember. So I said, like before starting the differentials, we can remember something when it comes to pain. So that is NIFTI, NIFTI, if you can write it down. So N start for neurological. Okay. So if patients coming with any pain, that can be from neurological cause. So for shoulder pain, if you go for N, that is cervical radiculopathy. And then I goes for infectious. So for every joint or any like muscle pain sort of thing, there can be a infectious cause. So especially for joints, it can be septic arthritis, and it can involve the bone, so it can be osteomyelitis. And we have the bursa, right? So covering the joint, so it can be bursitis. And then we have F, right? So F is for fracture. So you can ask the patient, do you have any history of recent trauma? So that F will cover, like it can be fracture or it can be some tear as well. And then T. So T is mostly covers all the trauma. So that can be from repetitive use. That can be from some accident as well. It's like RTA. And so there can be trauma, and trauma can cause like rotator cuff tear or shoulder dislocation sort of thing. And at last there is another I, that is inflammatory. So for every joint pain, there can be inflammatory cause, and that can be rheumatoid arthritis. And if these are symmetrical and involving the proximal joints, can be dermatomyositis or any cause of polymyositis. Polymyalgia rheumatica, it also involves both the, it's very common presentation in shoulder joint, or can also involve the waist as well. And so if you remember this NIFTI, it covers most of it. And there are other two things I remember with MO, M for malignancy, and O for others, like medication, or or for others like medication or any other things that we are not covering with NIFTI. So I think this is a very good approach of remembering any joint pain. So I'll go to the next slide. So first we'll discuss how to take the history of a patient coming with musculoskeletal pain. So we chose shoulder pain for that. So we all know the first question is like, I'll start from the first. So first, you always, like whenever you are even practicing, remember this pattern: knock, knock, enter the room, wash my hand with the sanitizer, give my candidate code to the doctor, and then introduce yourself. Very quick. Don't do it like super fancy. Make it very brief that this is Dr. X. I'm the physician on duty today, and then you can directly go, what brings you here? And after that, the patient will tell you, okay, I'm coming here with shoulder pain. So then you'll go to the onset. So always remember this specific pattern. There are like different resources. They have like sometime you'll find OCFD and sometime other patterns as well. Just remember onset and course. So in onset, you will just ask like when did it start? Very common question, and very important to know. Ask the second question is like did it begin suddenly or gradually? Because if the patient, because these are the questions that will narrow down your differentials. If the patient saying it is a sudden pain, then your brain will think more about trauma line, right? Like it's more like trauma or any recent infection or any recent changes like gout, like crystal arthritis. But if the patient telling you, okay, it was a gradual development, then we'll think about tendinopathy, osteoarthritis, frozen shoulder, fibromyalgia, this sort of thing. And another question. So if the patient saying it began suddenly, this is more appropriate to ask, what were you doing when it started? Or you can ask in any pain question, like even the patient coming with chest pain, any joint pain. It's very important to know what exactly the patient was doing, because most of the time when this kind of event happens, sometimes it can be from something they are doing, right? So for example, they're probably doing some household work, lifting something heavy that caused the pain. So it's very important to know what were that person doing when the pain started. Then we come to course. So for any pain, it's very important, or any presentation, for example, the patient's coming with vomiting as well, you need to know like is it getting worse from the time it started or it's the same. So for pain specialist, it's very important to know like the pain is still the same or getting worse. So if it's the same kind of pain, it's a constant pain, dull pain, then we'll think it's something chronic, right? But if it's getting worse and if the pain is more, then we'll think like, oh, there is something acute going on, can be a trauma related thing. And also the previous history will guide you, because we already asked what are you doing when it started, right? So you'll get another good idea. So every question you ask, narrow down your differentials. So by the time we'll complete this PQRST, we'll know like what are the exact question we need to ask for the differentials. Yeah, and it's very, very important to ask, is this the first time you're experiencing this or you have had this before? So that also narrow down a lot of differentials. And then again, the right question to ask is like, can you show me where the pain is? Or can you point out with your finger where the pain is? So if the patient's coming with shoulder pain, for example, they'll just point it out here. But if it's a radiculopathy, they'll show it's coming from the cervical region and then it's radiating towards the shoulder. So it gives you a good idea to what are the things to keep in your mind when you ask the question regarding your differentials. Then again, if you ask the patient, okay, so can you show me where the pain is? They also can show on the central chest and then show here. So you'll get an idea. Okay, so it's the MI. It can be MI that's radiating toward the right shoulder or left shoulder. And again, they can say, oh, I'm having pain in my abdomen as well. Then can show the shoulder. So you'll see, oh, it can be from the gallbladder. It's a referred pain. And then it's very important to ask the like symmetry. It's very, very important. Whenever you are having a joint pain, never miss this question. Is it in one shoulder? Is it on the right or left? Sometimes the patient will be saying, in the dorsal outside, it will be written like the patient presenting with right shoulder pain. And you're just asking all the question about right shoulder, but the reality is the patient is having both shoulder pain, and probably it's a like systemic condition, probably polymyalgia rheumatica, autoimmune disease. So it's very important to ask if patient presenting with one shoulder pain or any specific shoulder pain, rule out like if they have pain on the opposite one. And it's for knee pain as well, it's for ankle pain, because sometimes some presentation, or even it's for like small joint pains, like patient coming with pain in their hands. Sometimes they can have rheumatoid arthritis, right? So those have like symmetrical presentation, and sometimes they can have just osteoarthritis. Those will have like specific joint specific presentation, like can be unilateral. So it's very, very important to rule out, is it like unilateral or bilateral? And then again, you can ask any other joints. So whoever taking the class can note these points, because you're going to practice a lot of different joint pains, so you can use those when you are self practicing. Yeah, and as you know, after P comes the Q, was the quality. So it's very important to ask the question in a specific manner. Sometimes what we do, we don't have a format in our mind. So sometimes we are like, thinking first and then asking, okay, how would you describe the pain? Sometimes we think, can you like, what is the nature of the pain? So when you're practicing, I would say stick with one type of phrase that you are going to use in your real exam as well. Don't switch between your phrases. So sometimes what happens, you get confused like what to ask. So it's just for the practice and saving time in your exam. So stick with similar phrase. You can say, can you describe the nature of the pain? And nature is very important because it will give you again narrow down your differentials. If it's a sharp pain, it can be from some trauma like rotator cuff tear or impingement. And if the patient saying, oh, okay, so it's like a dull sort of pain, and it can be from frozen shoulder. And sometimes they can say, oh, I feel stiff in my joint, so then it will be osteoarthritis, rheumatoid arthritis, polymyalgia rheumatica. But not necessarily in quality of the pain. Patient will tell you, okay, I'm having stiffness. For joint pain, you'll have to ask this question separately. If they are mentioning this, well, you are asking about, can you describe the nature of the pain? You are good, you don't need to repeat the question. But if they are not telling you about the stiffness, you'll have to ask. We'll get to that in the coming slides. So after that, the radiation, we all know it's very important to know, like if it's radiating, especially for the neurological pain. Sometimes it starts from the cervical area, then it can radiate to the shoulder, it can radiate to all the way down to the hands, and it involves the dermatome, right? So whichever nerve is impinging, it will it will have distribution in those nerves area as well. And sorry, go back to the previous. Yeah. And for the severity is very important, because from a scale of 1 to 10, how bad is the pain? And sometimes you can mention, okay, from a scale of 1 to 10, 1 being the mildest and 10 being the worst pain of your life, how bad is the pain? Because 1 to 10 is like 0 to 10 is different for everyone. It depends on the pain threshold of the patient. Sometimes someone can say, oh, it's 10, but 10 is like, for him 10 is like 5 in other patient. So it depends. So you'll have to mention from 0 to 10, 0 being the like mildest pain, or 1 being the mildest pain of your life, and 10 being the worst pain of your life. How do you describe it? And then it comes to timing. So you'll have to ask if any specific time that the pain is worse. Sometimes some pain is like worse at night. Sometimes you have more pain in the morning, and sometimes it's end of the day, like mechanical pains are worse at the end of the day. So this PQRST we all know, but just describing what are the things we should look at and how it's going to help with narrowing down your differentials. So then how I remember is PQRST and AAA. So 1A is for aggravating factors. So it's very important to ask what makes it worse. So if you see here, reaching overhead, rotator cuff, or impingement, these are the differentials. And sometimes they can say, oh, I have difficulty wearing my shirt or combing my hair. You'll think more about this PMR, dermatomyositis. And then patient will say, activity makes it worse. So for osteoarthritis or mechanical arthritis, the more you do activity, it makes it worse. And sometimes they'll say like taking rest makes it worse, and with activity it gets better. So that's like inflammatory arthritis, rheumatoid arthritis, and those kind of inflammatory ones, reactive or like enteropathic or psoriatic arthritis. And then you can have patient presenting with neck movement, the pain get worse. So yeah. And then for elevating factors is the same. I've mentioned sometime for mechanical rest helps it, activity helps with inflammatory, and sometimes pain medication can also help. So now we'll come to the differentials. I have already mentioned these differentials, and some of you also contributed making this differential for shoulder pain. So we all know, but the most important here is the way you ask the question. So if you ask the PQRST, so you'll get an idea. Oh, is it from trauma, or what kind of pain is it? Is it a like gradual pain or such sudden pain? So that will help you narrow down your differentials. So if the pain is like more acute and the presentation is sudden and very severe, then you'll think more about trauma. So your questions will be initially on traumas, like history of trauma or history of fall or fracture. But like to complete your history, you'll have to ask other question as well. But you don't really need to ask a lot of question on those other things, because you already know what are the direction you are heading, right? So if they say it's a gradual pain, I'm having this pain for a long time, you'll think about, oh, it can be a frozen shoulder. So then you'll have to ask this question. So you'll have to ask if the stiffness comes on gradually, which already they told you, you don't need to repeat. Then you can say, can someone else move your shoulder fully? Why is so? Because if patient presenting with adhesive capsulitis, which is frozen shoulder, so they have stiffness on both active and passive movements. If they want to move it, it's difficult. If someone else wants to move it, that's also difficult. So that's the thing. And then again, I told like some of the diseases cause frozen shoulder. Diabetes is very common. You need to ask like, do you have a history of diabetes or thyroid disease? You can ask here as well. You don't need to wait for the past medical history. Sometimes you can just finish asking here. But what if you forget to ask here? So that's what your general history comes handy. That will help you exclude this, right? If you forget to ask this, but the patient has gradual pain, and from your general, you know, the patient's having diabetes, so it makes more sense, like the patient can have frozen shoulder. So I'll go to the next slide. Trauma we have discussed, and rotator cuff is mostly overhead activities. So they will have difficulty combing their hair, reaching overhead. Then you know, like there are different levels, right? They won't be able to do activities more than a certain degree, especially if it's overhead activities. Yeah. And now we come to osteoarthritis. So for any joint pain, especially if the patients are over 40, there is a chance of having osteoarthritis. So what happens in osteoarthritis, you have osteophytes or joint space narrowing. So that causes grinding or clicking sound. So it's very important. Whatever joint they're throwing at you, always remember to have this differential in your mind, and always ask this question. Do you have grinding or clicking sound when you move? And inflammatory arthritis, very important. So inflammatory arthritis, there are like 4 inflammatory arthritis, right? So I think if anyone can tell me what are the differentials for inflammatory arthritis. Hope you guys are still with me.
Yeah, in ankylosing spondylitis, there is sacroiliitis plus uveitis.
Yeah,
and
those differentials for inflammatory. Yeah,
it's ankylosing, reactive, psoriatic, and lupus,
and
arthritis,
and another one is like entropathic.
entropathic. Yeah.
So we have 4 differentials for inflammatory, right? These are the most common. Like these are seropositive. There are 4, and there are seronegatives one as well, right? So I think this ankylosing is the seronegative, and other ones are like seropositive. So we have a lot of question here. So how I remember it easily is from top to bottom. So if you think about your eyes, you should ask question about uveitis, right? And then you'll have to ask if your eyes become red or painful or sensitive to light. So that will cover 2 things. One is ankylosing spondylitis, and another one is reactive arthritis. So it's very important. And then you'll have to ask about rashes. So from eyes, I come to mouth. So you'll have to ask about, do you have any mouth ulcer? So it covers your lupus, right? and then after that I come to fingers. So I'll ask, it's more related to the nails. So there's the psoriatic arthritis. Do you have any changes in your nail or any pitting in your nails? And then you can go to the genitals, like do you have any genital ulcer? Or before genital, you can ask, do you have any pain in your abdomen, or do you have any history of diarrhea? So that's related to enteropathic arthritis. So top to bottom, so you won't miss any of the points of inflammatory arthritis. So why it is important? Because we have a lot of differentials here, and if the patient says I have ulcer in the mouth, I have genital ulcers, I have photosensitivity, painful eyes, your mind will go towards inflammatory causes. So it's very important to ask or rule out this question. Or when I said like to remember nifty, the last I goes for inflammatory. So you'll have to ask this question for any patient presenting with joint pain. Then if I come to septic arthritis, so this is something involving like different infections. So there are two type of infection, that is osteomyelitis. We know the infection of the bones. So osteomyelitis will give you a more chronic sort of presentation. So because this is, it goes for a long time, right? So they can have some fevers or chills or low grade fever, some weight loss as well. And sometimes it can be septic arthritis, that is like more common, like and more like acute. They'll tell you there's some redness in the shoulder, there's some swelling, there's some like tenderness in the shoulder. So these are the feature they'll give. But when you're asking about the inflammatory ones, it's very, very important to ask about the intravenous drug. Why it's important? Because it's very common to have joint infection, whoever shared the needles, right? And if you're forgetting to ask about the intravenous drug, you can also ask it from the general history, because we also take history about any recreational drug. So always remember, if someone's presenting with pain or like that can be from infection, if you're missing it on your associated symptom part, make sure you're asking it from your like general history on drugs. So ask if you take any IV drugs or intravenous drug. So it's important to remember. And for radiculopathy, exactly ask questions this way. Do you have any neck pain? If the pain shoots down towards your arm. And again, for radiculopathy, you'll have tingling, numbness, and weakness. So these are important. And for polymyalgia rheumatica, it will be more on like proximal muscle weakness, difficulty putting on shirt, combing your hair, and also very, very important. So these systemic disease, they have constitutional symptoms. So never forget to ask constitutional symptoms when someone presents with pain. Ask if there is any recent weight change, any fever, any like fatigue or weakness. So it's very, very important. And for polymyalgia rheumatica, this is a very specific question, because sometimes they present with giant cell arteritis, which is like another presentation of polymyalgia, very common presentation sometimes with polymyalgia rheumatica. So you need to ask, do you feel cord-like structure in your head, or in your scalp, or do you feel any tenderness when you comb your hair, any jaw pain when you are chewing? So it also excludes giant cell arteritis, which can be present with polymyalgia rheumatica. And sometimes patient with giant cell arteritis, they have changes in their vision. And they can have like sudden loss of vision, which is like intermittent. It's like a TIA. So it's also very important to rule out if there is any changes in their vision. And for dermatomyositis, we all know this is also involving the proximal muscles. For anyone coming with shoulder pain or hip pain, we need to remember this. And another very interesting thing I've mentioned before, fibromyalgia. So this is not very common, but sometimes this can be a presentation of any joint pain, because and this patient, they'll have tiredness, they have difficulty sleeping, and they have brain fog, difficulty concentrating, they have mood problems as well. Some patient can be anxious, some patient can be depressed. So it's important to keep it back of your mind when patients are presenting with pain. And for malignancy can cause any joint pain or any bone pain. So again, these constitutional symptoms. So it's very important to remember the constitutional symptoms. So whenever you are seeing in the door sign like the patient's presenting with pain, remember to write down in your paper about the constitutional symptoms so that you are not missing. And so I think you all know the constitutional symptoms, but for malignancy, if there are any lumps and bumps in your body. So after that, I think with these differentials, most of the red flag question will be excluded. So, but this night pain is a red flag for any kind of joint or bone pain, because it's mostly seen in malignancy, and again, it's a red flag. And sometimes progressing pain, you can ask if the pain is progressing and not controlled. That's a specific question. And neurological changes, sometimes what happens with this kind of joint or bone pain, it can involve the spinal cord or on the nerves coming out from the spinal cord. So then the patient can present with neurological symptoms. For example, if your patient's having any malignancy that involving the vertebra, like any bone malignancy involving vertebra, so those patients will have compressed spinal cord, and they'll have spinal cord compression symptoms as well. Sometimes patient will have bowel and bladder incontinence, so it's very important to remember. And general history, we all know how important it is. So I think on previous class, Saida gave some importance on this as well. So to remember this specific structure, PAM Hugs FOSS. So PAM Hugs FOSS goes for past medical history, allergy, and medication. So past medical history, you'll have to ask, is there any previous medical condition that you see doctor for? You shouldn't ask, do you have diabetes, do you have thyroid, do you have any history of stroke? Not like that. Just a single question, do you have any past medical history that you see doctor for? That's it. Go to the next one, allergy, and then medication. So you need to ask, are you on any regular medication? That's it, nothing else. No specific need of asking, are you on statin, or are you on rosuvastatin, atorvastatin? Nothing like that. Just ask, are you taking any regular medication? And then very important to also ask, are you taking any over-the-counter medication? Those are important for other cases. We'll whenever we'll practice those specific cases, I'll mention the importance of asking about the over-the-counter medication. So important to ask previous history, any previous hospitalization, because sometimes the patient can have previous history of shoulder surgery or previous history of shoulder injection, like steroid injection, which can do tendinopathy. Important to rule out urinary symptoms, very, very important when it comes to joints, because if they have urinary discharge, burning in the urine, those can cause symptoms like reactive arthritis, right? So it's very, very important. And then GI again, do you have any changes in your bowel habit? I've mentioned before about the smoking, alcohol, and recreational drug. If you see here, I've differently mentioned IVDU, IV drug use. It's very important to rule out. Then family history is important, because rheumatoid arthritis, autoimmune goes in the family. Occupation is very important. In this case, don't miss occupation, never. If someone presenting with you with pain and you're missing occupation, and the case is for counseling, right? So then it will be a huge mistake. You can even fail that station just missing occupation, because when you do the counseling after taking history, you won't know to tell the patient about doing some modifying work, or discuss about giving patient a sick note for resting couple of days before they continue to work, because the pain is coming from the kind of occupation they are on. For example, if they are heavy lifters, they work in any warehouse, or they work in constructions, it's important to know, like, if that's causing the pain. If you're missing this, it will be a key point in the whole history. So this general history is very important when it comes to joint pain or any bone pain. And then again, social history is important to know what they do at home, if they have support at home or not. And when it comes to shoulder pain or any joint pain, it's important to ask about the ICE. I think you guys know about this already. So it's just to know patients what are their perception about it, what they think of it, and if they're thinking what we can do for them. I think everyone knows about it. So far for shoulder pain, it's pretty much it. So we can practice this case if any one of you are ready. But before we practice, I would like to know, like, do you guys have any question or anything regarding this joint pain station? George or anyone, if anyone has any specific question.
No.
Okay, and we have this case with us today. So usually it's a history taking case, but and we'll get 8 minutes for this. But today for practice, I'll set 4 minutes. So I'll give 1 minute to 2 minutes for writing down your approach, or what are the structure you're going to follow while asking. So if anyone is interested practicing it today.
Yeah, I can.
So it's Bushra. Okay.
Yeah.
Okay, I'll just start my clock. I'll give you 1 minute 20 seconds. So that why we're doing it 4 minutes, because sometimes this can present with counseling, right? So you'll have to practice your histories like as quickly as possible, or within a short period of time, so that if they're giving you counseling or examination, so that you can do both of them within the distributed time. So usually you'll get 8 minutes for histories in a couple of station, but it can be 4 minutes as well, because you might need to do physical exam. They won't tell you like do your history in 4 minutes, do your physical in 4 minutes, but to do the complete examination and like good history, you should practice within 4 minutes, so that even if it takes 5 minutes, then you can do the physical examination in 3 minutes. But if you're practicing for 8 minutes and then you need to do physical exam and history within 8 minutes, then it gets difficult. So that's the reason we'll practice, most of our session will practice in 4 minutes, because if you can do it within 4 minutes, if they're throwing 8 minutes on you, it will be a piece of cake for you guys. So I'll start counting, okay, from now, and I'll give you 1 minute 20 seconds.
Okay.
Yeah, you can start now.
Okay. Knock, knock. I will enter in the room and give yellow sticker to the examiner. Okay, my name is Dr. And then I will sanitize my hand. Then I will say, I'm Dr. Bushra Suhail. I am your treating physician today. So can I confirm your name and age, please?
Yeah, my name is Sophia and I'm 42.
Okay. And how would you like to be pronounced?
You can call me Miss Sophia.
Okay, thank you. Okay, can you please tell me what brings you in here?
Yeah, doctor. So I'm having this pain on my right shoulder for last couple of days. It's bothering me.
Okay. When does this pain started?
Yeah, it's been an ongoing issue for me. So, but for last couple of days, I'm feeling like worse. It's going on for a couple of months.
Okay, so is it constant or gradual?
Yeah, I would say most of the time I have it, but sometimes it goes away as well.
Okay, is it progressing from the previous intensity?
Yeah, for last couple of days, I would say it's more, but it's not really getting that bad, but still there.
Okay, can you please pinpoint the position where you are feeling it?
Yeah, so I'm having the pain like all over here, and
Okay. Yeah. Does it radiate anywhere, like in your hand or
I
neck?
can't say it radiates, but I have pain in my body, and yeah, I get pain in
Okay.
other places. Sometimes it's more in other places, sometimes it's more here. Yeah.
Okay. So can you please rate it down? If I can ask you if you can rate it from 0 to 10, how much severe is this?
It can be like 6, 7.
Okay. So do you feel any stiffness in the morning?
No, not really.
Okay. And do you feel pain at night?
Night, I would say it's always there. Sometimes it's more at night. Yeah, you're right, doctor.
Okay. So, does it come with overhead activities? Like it's difficult for you to comb up your hair or to put on your shirt?
I wouldn't say that. It's always there. Like even if I'm doing those, it's there too. Yeah.
Okay. Um, and then, um, um, okay. Do you feel this pain on the left side as well, or it is just on the right?
Yeah, it's sometime on the left as well, but yeah, it's mostly on the right.
Okay. Or any other joint also get involved in it?
Yeah, so as I told you, like I have pain in different joints sometimes, sometimes more than one than other.
Okay, so do you feel it's red hot or like you feel like there is a clicking sound or grinding sound when you move?
So in my shoulder.
Yeah, no, actually, I'm asking right now about your knees, but yeah, you can tell about your shoulder as well. Like, do you feel any grinding or pain or clicking sound?
No, doctor. Why
Okay.
is it important to like have this kind of sounds or to get?
Yeah, sometimes these do happen if you have such kind of pains.
Okay.
Yeah. Okay. Then, is there any particular disease that runs in your family?
And yeah, my mother has diabetes. Yeah.
Okay, diabetes. Yeah.
Yeah.
So,
Yeah. It's like-
are you taking
I'll,
any?
I'll give you one more minute. Okay.
Okay. Are you taking any regular medicines or
Yeah,
any over the
I just
counter
take some supplements. Yeah.
supplements? Okay. What kind of supplements those are?
Just some vitamins and yeah.
Okay, so did you ever feel your eyes are painful and red?
My eyes?
Yeah.
Oh no.
Okay, did you feel any burning urine?
No.
Okay, any mouth ulcers,
No.
nail pitting,
No.
or rashes? Okay, okay. So, and then what else? Okay, did you feel like anything that your pain gets worse or better with anything?
Sometime with good sleep, it helps. Yeah.
Okay, okay.
Yeah, I think our time ends here. I've given
Okay.
you about 5 minutes.
Okay.
So yeah, you did a good job. Yeah.
Yeah, actually, I just write your history points, but I think so. It's not up to the mark.
Yeah, no worries. You're just starting out, so it's a good job. Yeah. So, but is it okay if I give you feedbacks? Like,
Yeah, sure. I really want that.
yeah. And so you started. The thing is, I think you're not practicing a lot. So the initial part you struggled a little, and that killed some of your time. Like
Yeah.
you entered the room, then saying as you got little confused. So that's fine. That will come with practice. So and in exam you don't need to verbalize this, you just do this quickly. But for everyone, keep practicing from now on, so that when you go to the exam, this also doesn't take a lot of time, right? Because sometimes giving the sticker and washing your hand and just entering a station can be a bit overwhelming, so it kills time. Like 20 to 30 seconds goes into it. So always practice while you are doing at home, so that it saves some of your time. So the first thing is like your orientation was little haphazard. So you are just moving back and forth from your general history and your pain presentation or the differentials. So that you'll have to work on. And for describing the pain, uh, I think you ask about the radiation, but when you're asking about the severity, what I mentioned, you should clarify that one being the mildest pain and 10 being the worst, so that the patient knows what exactly you're asking. Because
Yeah.
pain threshold is again depends. So I said, like, I intentionally said like it's 7, but if you tell me like worse than mild, I would be able to know like, oh, it's probably a 4.
Okay.
And then in your like all the aggravating and elevating factor, you're like going back and forth, like, so
Yeah.
so whoever will doing the whoever will be the examiner in your case, so they'll have a checklist. So the problem is, like, even if you are asking all the question but you're going back and forth, so it gets difficult for them to keep a track of your points. So sometimes you might lose mark in that way. So I don't know, before doing the case, did you write all those points in your paper?
Yeah.
So
I did.
yeah, so I know it's your first time, or you're just in your early days, so it's okay to go back and forth. But what you need to do is like stick to that OCP QRST pattern, and then elevating aggravating factors. Okay,
Okay.
so in that way you will be more systematic, and
Yeah.
you have a fixed structure. And coming to your questions, like you didn't ask the constitutional ones, which is very very,
Yeah. Mm.
you'll lose a lot of marks if you miss that. And then I told all of you, like, when I was doing the differentials, to write nifty, right? So
Yeah.
so that you don't miss. So you could have used that one, because your differentials, you're asking questions, then you are asking general questions, and again back to your differentials. So it was really difficult to follow you. So you lose mark in that way. Constitutional one, you lose mark. And the timing, that will come with time, but you should focus more on your timing. Even if you see, okay, I'm not finishing my questions, you should come to your general ones, so that you at least finish the station, because you have marks for all the points, right? For general history, you'll have mark for individual history, for family history, occupation, and all. So these are the important ones. So, is there anyone who wants to do the case again? Then I'll discuss the differentials. I would say, anyone
Yes,
can?
I will.
Okay, okay, great. Okay, so I'll give you the same amount of time,
Okay.
1 minute, 20 seconds, and then we'll practice it again, okay?
Okay.
Your turn starts now.
Okay.
Okay, so you can start the
Okay.
case. Yeah.
Okay. Hello, my name is George, and I'm your physician today. How would you like me to address you?
Yeah, you can call me Sarah.
Okay, so I hear you are here complaining of shoulder pain. So
Yeah.
I would like to, for the next few minutes, I'll be asking you a few questions to get to know what's happening to you, to come up with a better plan for you. Okay.
Yeah. Yeah, sure.
Okay. All right. So first of all, I'd like to ask you, when did the pain start?
So started like a couple of days back.
Okay. Was it gradual in onset or it was sudden in onset?
It was, I would say, gradual. Yeah.
Okay. And since it started, have you seen any improvements? Is it the same or is it
Yeah.
becoming
So I'm
worse?
suffering from this pain. Like these are bothering me. It's bad, doctor. It's
No,
affecting my quality of life.
sorry about that. Okay. And since it started, is there, can you point to me where exactly you feel the pain?
Yeah. So now the pain is on my right shoulder, like here, doctor. It's all diffuse. It's very bothersome.
Okay. Can you describe the pain for me? Is it sharp? Is it burning? Is it um, stiff? How do you describe the pain?
Yeah, I would say it's a dull pain, doctor.
Okay. Does it radiate to any other parts of your body or your arm?
What do you mean by radiate, doctor?
Does the pain move? Do you feel it in any other parts of your hand? Does it move?
Oh, yeah, yeah. I said like I have pains in different parts of my body. It's just one of the pain, doctor. Is on the right shoulder now.
Okay. On a scale of 1 to 10, 1 being the least pain and then 10 being more painful, how would you describe the pain?
Yeah, I would say it's 4, doctor.
Okay. So is there anything you do that worsens the pain, like movements, assuming a certain posture?
No, I think day-to-day activities makes it worse.
Is
Yeah.
there anything you do that makes the pain better, like resting or assuming a certain posture?
I would say like after good night's sleep, like like refreshing sleep, I feel little better. Yeah.
Okay. Do you experience any morning stiffness?
No.
Okay. So have you noticed any swelling in your shoulder?
No.
What of any bruising in the shoulder?
No.
Any abnormal posture of your hand?
No.
Okay. And since the pain started, have you experienced anything like fever? Night sweats?
I wouldn't
Okay.
say fever. I feel feverish. I feel hot. Yeah.
Okay. Any history of night sweats?
No. No night sweat.
Weight loss?
No.
Okay. So since the pain started, do you have any issue with weakness in any part of your hands?
No. No hand weakness. No.
Okay. Any tingling sensation in your hands?
No.
Do you feel the pain in any other parts of your body, in the other shoulder, and any other parts of your joints?
No, not other shoulders, but as I mentioned, like I think the pain runs in different part of my body, doctor.
Okay.
Yeah.
And do you have any problems combing your hair? Any weakness when you try combing your hair?
No.
Any pain or tenderness in your scalp when you try combing your hair?
No.
Any joint pain or joint stiffness?
No, I said this before. I don't have
Okay.
stiffness. Yeah.
Any blood vision?
No.
Okay. Any rashes on your knuckles or any other parts of your body?
No, doctor.
Okay. So do you have any known medical condition like autoimmune condition, hypertension, diabetes?
No.
Have you had any surgeries done before?
No surgery. No.
Do you have any known allergies?
No.
Are you on any medication, or do you take any over-the-counter medication?
I just take the supplements.
Okay, what supplement? Do you know their names and why do you take them?
Yeah, I just taking vitamin supplements. Yeah, for my health.
Okay, do you have any known medication allergies?
No.
Okay, is there any family history of osteoarthritis, rheumatoid arthritis,
No.
polymyalgia rheumatica?
What's that?
Is an autoimmune condition? Is there any other autoimmune condition in your family?
No, not that I know of.
Any history of diabetes, hypertension?
Like in family?
In family, yeah.
Yeah, my mother had diabetes. Yeah.
Okay, how long has she had the diabetes for?
40 years.
Is she on any medications for the diabetes?
Yeah, she take bunch of oral medication and I think insulin as well.
Okay, but is she doing okay? No complications?
Yeah, I think your
Okay.
time's over. Yeah.
Okay.
Yeah. Yeah, George, so excellent job. You could at least finish the station, so that's good, and it feels like you have been practicing. That's visible from your questions. But yeah, there are a lot of points you also missed. So you didn't do the door signs like knock knock, entering the room. Okay, you missed that. So always try to practice whenever you are practicing at home with that. Okay, so that you don't
Okay.
forget in your exam. Then you missed a very key point here. Uh,
Mhm.
you didn't ask, may I confirm your name and age?
Okay.
You directly went into, can I? How should I address you as? Okay. So
Okay.
first, because it can be a different patient room, right?
Mhm.
You you,
Mhm.
you can do the whole history in a wrong patient. So it's very important to confirm the name and age.
Okay.
And then you did the PQRST in a good manner. Though I think you also asked the constitutional symptoms. That's good. Your differentials were also good, but I think you could do that nifty pattern more structurally. Okay.
Okay.
Yeah,
Okay.
you ruled out the inflammatory ones. It looked like you're thinking about a lot of differentials. You did the systemic one, like the dermatomyositis, and other ones really good. So that's a good point. But you asked a lot of unnecessary question when it came to the
Mhm.
mother history, because
Okay.
what the mother's taking nothing to do with the patient's pain, right?
Okay.
The mother's medication or how is the diabetics controlled. So if you would skip those questions, you could also save some time.
Okay.
And another problem was you asked repeated question about stiffness, so
Yeah.
that would look like to the examiner that you're not listening, you're just
Okay.
focusing on your own agenda, so that also kills your mark. Okay, but
Okay.
otherwise for the I don't know how long you've been practicing, it's a good way to start and go about it. Okay,
Okay.
I'll come to Bushra first. So what do you think, what
Yeah.
the case was on?
Yeah. I feel like it's fibromyalgia.
Okay, and
Yeah.
George, what do you think, what was your top differential?
My top differential was fibromyalgia too, because
Yeah,
there were no red flags and
yeah, yeah. I think
yeah.
both of you are exactly on point. So it's fibromyalgia, but for shoulder pain, it like it's not common, but they can trick you with this kind of station. That's why I felt like keeping a like unique differentials, and it can come in any exam, right? Because this is the way they can trick you. So both of you did well as a beginner, like the approach was good. I think for Bushra you'll require more practice, and these feedbacks I'm giving you guys, just work on this area so that you can get a fluency, or you can save your time. So for both of you, I just gave you 4 minutes, 4 to 5 minutes, and you could almost finish the cases, especially George. So I would say keep up the good works, take the feedbacks and keep practicing. Okay, so I'll go to my next case. I think this will be a bit little quick because we have already described those pains, right? So PQRST. So I won't further go deep into it. But for this, for chest pain, if anyone would voluntarily give me some differentials, or if you can give me some structured differentials with system. Anyone? Let's ask to someone who are not responding a lot. I think Noshin, are you here with us? Or Osu, like
Any differential for chest pain?
yeah,
I'm sorry, it's Silora.
yeah.
Yeah, I think ACS, then pulmonary embolism, then then should I say like MI?
Yeah,
Yeah, then
ACS comes under MI comes
under ACS. Yeah.
yeah.
Um,
Yeah, so the thing is, what I want you guys to do, like if you are encountering any symptom, always think with the like system, right? So don't start thinking about important ones. So that way you'll miss some differentials. So it's important to think about all the systems and then think about the differentials. For example, for cardiac, what do you have? One is ACS, right? It's stable and unstable angina and MI. And then what else?
GI,
Right?
GERD, GI. It
That's
could be
for
the GERD.
gastrointestinal, right? I'm still on cardiac.
Okay.
Pericarditis.
ACS, right?
Aortic dissection.
Aortic dissection is very excellent one. Yeah. And anything else?
Pericarditis.
Great. And what else? Anything? So basically these three are the top ones. Okay, so like aortic dissection is an acute one. So whenever we talk about differentials, try to put the differentials that can kill the patient life, because you are taking this NAC OSCE exam. Here they want to see if you are considering this life threatening one in your differentials, or are you a safe doctor or not. Okay, so always keep these top like life threatening or emergency differentials in your top list. ACS can definitely kill the patient. Aortic dissection can kill the patient, right? Pericarditis is another important one. And these are three. I think there are other couple of ones. We'll go into that. And then if you come to pulmonology, what are the ones?
Pulmonary embolism.
Very important one, can kill the patient. If you
Pneumonia can have some chest pain.
For
Neuritic chest
yeah,
pain.
yeah, it's a classical symptom of pneumonia. Yeah.
Pneumothorax.
Pneumothorax, tension pneumothorax is an acute one, very, very important. And what else? Sometimes you can have chest pain from acute exacerbation of chest events as well, right? AECOPD, acute exacerbation of COPD as well. Those can cause, but not very common. And what are the other system? Like for GI, someone mentioned GERD, right?
Yeah, it's GERD.
And what else from GI? What can you remember? All the infection involving the upper part, right? Esophagitis. From
Esophageal rupture.
Yeah, esophageal rupture.
Diffuse esophageal spasm.
Exactly, yeah. So these
Eclampsia.
are these are from GI, right? So and what else we have? What can cause chest pain? I'm just going through all of these, and you guys are participating so that when you study alone, you can remember more differentials, right?
Muscle pain.
Osteochondritis.
Exactly.
Osteochondritis,
Yeah, osteochondritis is very common. Yeah, muscular pain can be one. Yeah, and anything else that you can remember?
Trauma.
Psychiatry, like the panic attack.
Yeah, sometimes they can have some chest pain sort of presentation as well. Okay, I think most of the differentials are covered. Let's see if anything we missed. So for cardiac, we answered everything except for the tamponade. Okay, very important. Sometimes severe aortic stenosis, not the mild or moderate. If the patient's having severe aortic stenosis, that can present with chest pain. And for rest, you guys have mentioned excellent. And for GI, we have mentioned everything. Sometimes herpes zoster, it can be painful. It can have some vesicular rash and can be really painful. So most of it, I think we have answered. So I won't discuss anything about it here. So again, for pain, it's important to have OCP QRST, right? So here, sudden or gradual, we need to rule out, because sudden are mostly the top ones from cardiac and pulmonology, right? But if you see the gradual one, you have pulmo or cardiac causes as well, but it's GERD, pericarditis, subacute things, right? That will not kill the patient immediately. And course is very important. Sometimes it's getting worse, like for example, unstable angina or MI, they present with pain and that keeps on getting worse, severe or worse pain of their life. And it's very important to know like, is it constant or comes and go, right? So sometimes some patient can have intermittent pain, for example. That will be more about angina or aortic stenosis I mentioned, right? So in moderate to severe aortic stenosis with exertion, they'll have chest pain, and they can have shortness of breath as well. Position is very important, because if the patient coming with chest pain, sometimes we have this tendency to think, oh yeah, it's MI, right? But again, it can be just a costochondritis. So it's very important to ask about the position. Can you show me with your finger where the pain is? So then you'll see the patient's pointing out in one of the ribs. So then your brain will go into more into muscular. But again, if the patient's coming with chest pain, even they're showing you with their fingers, so it's on my ribs, you'll have to make sure you're excluding the life-threatening differentials. Okay, you will have to ask those questions. Oh, is it going back? Is it very severe? Is it teary, like it's going back, like aortic dissection? Is it the worst pain of your life? Is it radiating? So these you'll cover from PQRST, but when you think about the differentials, even if you think, oh, it's from musculoskeletal cause, don't assume early. Try to rule out those life-threatening causes. That way, the examiner will think, oh, she's or he's a like safe doctor, and that will increase your marks, because they will have, if the station coming with chest pain, and you're just, even from your history, you're getting that direction of musculoskeletal or those sort of pain, it's important to rule out the most important or life-threatening causes. Okay. Again, radiation, we all know, MI goes to the jaw, left arm. I mentioned aortic dissection goes to the back. GERD, the pain. The interesting thing is, if you can have station where patient presenting with chest pain, and the patient, when you're asking, the patient will show the lower part of the chest, or it can be the epigastrium. So it can be from GERD, because from history, you'll have to rule out from where exactly the pain is. So it's very important to ask the patient, can you show me what the pain is, or can you show with your finger what the pain is, so you know the exact point. Severity, again, very, very important. For severe pain, dissection, MI, it will be severe pain. And again, for aortic stenosis and angina, it will be severe on exertion. Timing is important. Sometimes is it constant or comes and go? For like joint pain, we don't need to ask, is it like worse during any specific part of the day? Not important, right? So we'll have to ask like about the consistency, like is it constant or it's intermittent? Very, very important to know what aggravates it. Very important to know what helps with it. So for here, it's important, like after eating, does it get worse? So if you're asking this, the examiner will know you're thinking about GERD. So then you'll think, oh, you have some differentials in your head. And you need to ask, if you're leaning forward, is it getting better? Any medication helps with the pain. Important. Sometimes they said, oh, I took Tylenol and the pain is there. Because if someone's having severe pain, what first thing they will do? They'll have Tylenol at home. They take Tylenol, MI doesn't work, right? So these will give you ideas to think about your differentials, because in your paper, before entering the station, you write a lot of differentials, but you only have 8 minutes. You won't be able to ask a lot of questions. So in exam, it's important to narrow down your differentials, keep the top ones or life-threatening ones, and just focus more on the important ones, right? Like here for chest pain, you have like how many? 15 to 20 differentials. You don't need to ask so many questions. If you think it's a central chest pain, it's huge, it's like severe pain, worst pain of their life, you don't need to ask them, oh, do you have any point tenderness, or do you have enough pain is more when you move or breathe? You don't need to ask that question, because it's more related to costochondritis. And again, these questions are super important. You need to know for MI what you need to ask. Any shortness of breath. So always remember, if the patient coming with chest pain and or shortness of breath or dizziness or palpitation, there are a couple of questions that you need to ask. These are 4 like very important question or specific question. Anyone coming with chest pain, always ask about shortness of breath. Always ask about if they're having any heart racing. Always ask about do you feel dizzy? Okay, these are related questions. Someone coming with shortness of breath, always ask, do you have any chest pain? Do you have any cough? Do you have any dizziness? Do you feel your heart racing? These questions are interlinked, so never miss this question. So before coming into differentials, ask this, because someone presenting with shortness of breath, it can be a presentation of chest pain, but you are missing these important points, right? Someone coming with severe aortic stenosis and on exertion they are having shortness of breath, they can have chest pain as well. Don't forget to ask this question, okay? And aortic stenosis, they can have this dizziness spell as well. And any structural change in your heart can force you into atrial fibrillation. So ask if your heart is like racing fast or not. So these 4 questions: chest pain, shortness of breath, dizziness, and cough. Try to, or heart racing, try to ask this question like whenever you're finding any symptom in your exam, like chest pain, shortness of breath. And for stable angina, it's very, very important to know if they had similar episodes, or even for when you are asking the initial questions, it's very important. What were you doing when this happened? When I was like discussing about shoulder pain, I also told like what were you doing when you had this pain? Because there can be acute event. Probably they were doing some gardening, they're lifting something heavy, and they have some structural problem. They're going into this chest pain now from severe aortic stenosis. So to narrow down your differentials, to be a to score better in your exam, never miss these questions. Because from cardiac system, when I was discussing in my first class, so we have a very good chance of getting one case. So go through all the symptoms of cardiovascular system, so that whatever they're throwing at you, you're really getting good marks. And then aortic dissection, because they're bleeding, right? So they can faint, they can feel weakness, numbness, and then change of blood pressure because they're losing blood. So they'll go into hypotension. For aortic stenosis, as I've already discussed, like, is it more with exertion? Always remember this. This is something people forget. And pericarditis, do you have any recent fever or flu-like symptoms? Always remember these questions, these points, because these will save your time. If you are thinking differentials, pericarditis, oh, what I need to ask, you need to think about all the causes of pericarditis. But no, when you are practicing, just memorize this, in a way, so that this comes automatically. You don't need to think a lot. Oh, for viral illness, what I need to ask? Because most of us, English is not our native language. We need to think in our own language, then we interpret, right? So always think, okay, for pericarditis, do you have any fever or flu-like symptoms? Do you have any autoimmune disease? Any history of heart attack or heart surgery? So that we know like there were any cardiac events that pushing into pericarditis now. So this is what we encourage everyone, whoever preparing, whenever you are reading a differential diagnosis, just not read that differential diagnosis, read those points beneath those differentials, those etiologies responsible for those differentials. Very, very important. Someone mentioned P, so I think that was Elora. So any sudden shortness of breath, coughing of blood, P is very, very important. For shortness of breath, for chest pain, never miss P. And this is something very common in Canada. You find tons of patients in the hospital, and for all the patients in the hospital, they're on prophylaxis for pulmonary embolism, like DVT prophylaxis, basically, all the patients. So it's very, very important. And these kind of cases are, I think, more here compared to back home. So any shortness of breath, any cough pain, swelling or redness, which you are ruling out DVT, any recent surgery, immobilization, I would say these are all the etiology of pulmonary embolism. So memorize. Like, so that will save your time. You guys know all of this. And I don't think anyone here doesn't know what are the etiology of P. But when you ask this question, you need to think, so that like when you go to the exam, if you are memorizing, or the way of you are going to ask this question, if you have like predetermined in your head, so that it's going to save a lot of your time. Pneumothorax, like any sudden shortness of breath, you'll get this, and any asthma, COPD or lung disease, to know like if they have previous lung blebs or something that's like perforating now and doing pneumothorax. After that, pneumonia, so fever or chills, cough, sputum. GRD, very important to know about if related to food intake or not, anything help like antacid or not. So these are the most of the thing. You don't need to ask a lot of question on esophageal ones, unless it feels like, oh, you're not finding out the exact causes. So any difficulty swallowing, any pain, you can just quickly ask this question. And for anxiety and panic attack, you can ask this one question: are you the type of person who is anxious most of the time? Did you have any panic attack, or like tingling or trembling type of sensation? So very quickly, if you don't find any exact causes, like if you are sure that this is MI, and you have ruled out other important causes. Don't need to waste your time looking after psychiatric conditions like panic attack. It's not that important. So this is how you save your time. You narrow down your differentials, you focus on the most important life threatening ones. You are sure that your differentials are like you're going towards a right differential. You just quickly move to general, okay, just to finish in time. So here you get the red flags. Most of them will come from different differentials. So tearing back, aortic stenosis, hemoptysis, hypotension, these all from aortic stenosis. So yeah, and general we have discussed so many times. Is past medical history. You don't need to ask, do you have any history of MI, any heart disease? No, you ask, do you have any past medical history you see doctor for? If there is any, the SP will tell you right away. And this is how you save your time. Are you on any medication? I think for all the classes we'll conduct will emphasis on saving the time, because time is money here, and time is everything. And you don't ask any extra question. Very important, this smoking, alcohol, cocaine. So you'll ask this question exactly. Do you smoke? Yes, I smoke. How many cigarettes a day? Okay, one pack a day. For how many years? For 30 years. Done. Move to how much alcohol do you drink a week? Ask exactly the same way. We did it, and we saved our time, and it was a great way to finish the history with a certain period of time. Go to family history. Do you have any past family history? Don't need to say, do you have anyone diabetic in your family? No, just ask, like, do you have any family history of any condition? Occupation sometimes important, like to know. If you have time, ask about it. Sometime social support not super important, but this is like this drugs history is very, very important here. Family history not that important, but in one line, do you have any family history, any medical condition in your family? Yeah, so this is the last case that we are going to practice. So I would like someone who didn't practice today. So this is a class where no one's going to judge you, so it's a good way to practice. So whoever didn't practice yet can come forward, because if you practice in this kind of situation where other people are seeing, it will boost your confidence. We're all here to cheer you guys, so no worries. So I think someone who didn't practice today.
I want to practice.
Okay, so I think Elora wants to practice. I'll give you 1 minute 30 seconds to write note, and then I'll give you 4 minutes to practice the case. Your time starts now. Do you need a minute to find your paper, or you have it with you?
Actually, I don't have, but I can try. One thing, just want to ask about the question that because of I need to find out the cause, yeah?
Oh, it's chest pain. Sorry, my bad.
That's a
It's a chest pain. Yeah. 28-year-old female came to your emergency because of chest pain. Yeah. Yeah, counting the time from now.
So I can start now?
No, you still have. Okay, if you're ready, sure. Are you ready?
Yeah, I'm ready. Yeah.
Okay, I'll give you 4 minutes. Yeah.
Okay. Knock, knock. I'll enter the room. I'll pass my yellow sticker to the examiner. I'll sanitize my hand. Good evening. My name is Dr. Elora. I'm one of the treating physician of this emergency today. Before I start, may I confirm your name and age, please?
Yeah, my name is Sarah and I'm 28.
Okay, Sarah, how would you like to address?
So you can tell me Sarah. Yeah.
Okay, thank you. So, what brings you here today?
Yeah, so doctor, I'm having this chest pain since morning and started yesterday, wasn't that bad. I'm having this chest pain. I'm very worried. One of my friend died with chest pain.
I'm so sorry to hear that. It must be stressful for you. So, I will ask more questions
Am I
to
going
find
to
out.
die, doctor?
Uh, l- let's ask more question, then I can assure you like what's going on. We'll work together. We'll find out the cause and we'll work together. It's okay? Is
Yeah,
it okay for you?
sure,
Yeah.
doctor, sure.
So you said it started from the morning, and you said it was also yesterday as well. So, so how do you say like it's when it start? Yes, from yesterday or since the morning?
Yeah, so it started yesterday. I thought like it's from some gastritis and heartburn, but it still persisted, and this from this morning, I think it's getting worse, doctor.
Okay. So is it a sudden pain or it's a gradual pain?
Yeah, so gradually it started yesterday. Yeah, it's a gradual one, doctor.
Gradual, and if the pain is always there, or you feel like you have some
Yeah,
pain interval.
yeah, it's always there, doctor, and it's worrying me because I know my one of my friend died with this kind of pain. Am I going to die?
Uh, we'll ask more question. I will ask you more question, and let's find it out. Let's hang on with me. Let's ask more question, and then I can give you a good explanation. Is it okay for you?
Yeah, thank you, doctor.
Okay. So, what makes it worse? Like, what makes it more bad?
So I would say when I lie down, doctor, it's getting worse.
Okay. And what makes it better?
I think sitting and just coming forward, it helps. Yeah, doctor.
Okay. So, how do you describe the quality of the pain? Is it sharp, burning, tearing, pressure like?
No, it's not like that. I think it's dull, doctor.
Thank you. And is the pain radiate anywhere?
Not really, no, doctor.
If I ask you the severity, if the 0 is the lowest pain of your life and 10 is the highest, how do you rate the pain?
I would say it's a 5 or 6.
Okay.
But when it
Yeah.
started, it was like 4. So it's getting worse, doctor.
Mm-hmm. And is there any shortness of breath?
No.
Any palpitation?
What do you mean by palpitation?
Do you feel your heart is racing?
Oh, no, no, doctor.
Do you have any sweating?
No.
Any nausea or vomiting?
No.
Um, any dizziness like lightheadedness?
No.
Any shortness of breath when you are in lying posture?
Yeah, I told you, I have chest pain. Yes, yeah, I'm having some shortness of breath too. Yeah.
Mm-hmm. Do you have any leg swelling?
No.
Any cough?
Cough swelling?
Yeah, cough means like cough and sputum. Do you have any cough or sputum? Like
Oh, no, no.
any fever or chills?
Yeah, I think I'm also little feverish. Yeah, I think slightly feverish. Yeah.
For how many days?
Yeah, I think for last couple of days, I'm feeling little feverish.
Okay. Do you have any history of heartburn?
Heartburn, yeah, here and there. I take an antacid and that helps, doctor. So yeah, that's controlled. Yeah.
Any difficulty in swallowing?
Swallowing? No,
Yes.
really.
Pain after meal?
No,
Do you feel any pain with the movement?
no,
Do you have any fever? You said sorry, weight loss. Do you have any weight loss?
no,
Do you have any night sweat?
no,
Do you have any lumps and bumps in the body?
no.
Do you feel that you said that when you lean forward you feel chest pain? Yeah. Do you feel that the pain increase with the exertion?
Like movement?
Yes, like exertion, like any heavy work or.
Uh,
Uh,
Your time's over. I give you 5 minutes, 1 minute extra. So you can continue. I'll
Yeah.
let you continue. One more minute. Yeah.
Any history of coughing up of blood?
No. No.
Any cough pain?
No.
Any recent surgery?
No.
Any history of long prolonged bed rest?
No.
Do you use any oral contraceptive pill?
Yeah, I do.
For how long?
Yeah, I've been using for last 8 years.
8 years.
Yeah.
And may I know the name of the contraceptives?
I'm just taking there's a combination pill that's it.
Okay.
Like
Okay.
it's estrogen and progesterone. Yeah.
Mm-hmm. Okay. Do you feel any back pain with these symptoms?
No.
Okay. Do you have any disease or any condition for which your doctor is following you? Any past medical history?
Yeah. So I have one condition they call lupus.
Okay. So how long you have been diagnosed with lupus?
Like for last 5 years.
Okay. And are you taking any medicine for that?
Yeah. So they gave me prednisone and hydroxychloroquine.
Okay. Thank you for the information. Do you have any history of allergy?
No.
Any medicine with prednisolone and hydroxychloroquine, yeah? You said?
Yeah.
Any medicine with this, are you taking any other medicine with these medicines?
No.
Any history of, you said that, any history of urinary discomfort?
No.
So when was your first day of last menstrual period?
That was like 2 weeks back.
Do you have any history of miscarriage?
No.
Okay. What is your job?
Yeah, I work as a social worker.
And do you have any history of smoking?
Yeah, I smoke here and there, like not regularly.
Do you have any history of alcohol?
Yeah, I socially drink sometimes, but not often. Yeah.
Do you have any history of using any recreational medication or any IV medicine?
Yeah,
IV drugs?
here and there. Your time's over. It's almost 8 minutes. Yeah. So I gave you almost 8 minutes, but see, you almost got it. But yeah. So I would like to ask you guys, like, what are your top differentials?
It's lupus pericarditis.
Okay, and what else? Like, is the diagnosis right? What are the differentials? Top differentials you'll think?
Myocarditis?
Okay. And anything?
Viral pericarditis.
Okay. Yeah. Yeah. So you can say pericarditis that can be from different causes. Yeah, viral or lupus. Yeah. Yeah. So you did good. You're like oriented and asked a good amount of questions. But again, it can, if you say like history and counseling, so you'll feel short of time, right? So
Yes.
the things about you was you started well, you were organized, but OCP QRST it could have been more organized. You were like asking the question for position, then switching back and forth. For severity, you mentioned from 1 to 10, 1 being the mildest. That was good. And I saw you asking questions about some anxiety as well, right? So anxiety and also difficulty swallowing. But as you got the clue that the patient's leaning forward, it helping, on lying down, it getting worse, right? So stick to the life-threatening and the more appropriate one. You don't need to go to esophagitis or any swallowing difficulty for this. And for past medical history, I think it could have been more concise. I think it will come with practice. Like the more you'll practice the exact phrases. For example, do you have any past medical history? That's it, right? Nothing else. And or do you have any past medical condition that you follow up with any doctor? Done. Any history of allergy? Done. Are you on any medication? That's it. You don't need to say, are you on any other medication with these and these, right? That kills time. So to be concise, are you on any medication? Are you on any over-the-counter medication? Are you taking any over-the-counter medication, right? For urinary changes, do you have any recent changes in your urine? Done. Any recent change in your bowel movements? For smoking, when I said, yeah, I smoke here and there, you should ask how many sticks a day,
Sticks in a day.
for how
Yes.
many years. And the thing is, I can say, okay, I'm smoking like one packet a day for like 10 years, then I quit like 5 years back, and now I'm socially smoking, right? It can be a history. And for alcohol, for everyone, how much alcohol you drink a week, okay? And if you're like, do you drink alcohol? Yes. How much alcohol? Yes. How much a week? 3 questions. So you cut it down to 1 question. How much alcohol you drink a week? Okay, and that answers 2-3 questions in one go. And you were asking me about the fever again. You caught it yourself, so don't repeat. Okay, I know it's difficult sometimes. So write it down.
It happens
Yeah,
like that. Twice, it's very common.
It happens with everyone, but the thing is, whenever you are finding something, like you have the note, write it down, or like give a tick beside that, so that you can move forward. So it will come with practice. You did good. I think whoever didn't practice today, if we are conducting session next time, they can do it.
One question I do have, like the last question I had, that the patient said that the patient has here and there IV drug use or recreational medicine. Like, could be, like the this history. How would we elaborate? Like, if somebody give us history, like they have IV drug use or something recreational drug use history.
Yeah. So, for example, if you're asking, do you do any IV drug, right? Or intravenous drug? They'll say yes. You can ask, like, do you share needle? Okay. To know, like, if they're doing it with their needle, what will happen? Nothing, right? The only time they'll get infection if they're using or sharing needles. They can get it from someone else. Or can you ask, where do you do it? Do you do in the streets, in an unhygienic place where if something can get into their IV? So these are the questions. You don't need to like ask a lot of questions, just 1 or 2 questions. If it's positive, for example, it can be one of the case of endocarditis as well, right? Rare, the differential.
Yes, infective endocarditis could be one difference.
Yeah, but in that case, it will be a chronic presentation, right? They'll have fever. I said low fever, so it's good to rule out that one as well. So your history, your clinical knowledge will judge, guide you. But the thing is, you'll have to narrow down your differentials to life-threatening one, most appropriate one first. If you have time, if you have whole 8 minutes, you can also ask about those esophagitis and all. No harm in it, but keep it like in a format. Like if you're writing down GERD, you're asking like the pain changes after taking meal. Done. Do you have any history of heartburn? Done. Just 2 questions, right? And then you move forward to your next one. So for everyone, it's very important to practice. It's very important to write down in your sheet what are the questions you are going to ask, and then go about it. Okay.
One more question. This patient basically twice or thrice ask me, am I going to die? Am I going to die? And this kind of situation, how should we approach with the patient? Like how should we reassure the patient?
Yeah. So the big part of this NAC OSCE is like dealing with different patients. I did it like intentionally. So in your like real exam, you'll find cases where you'll encounter angry patient, you'll encounter anxious patients. For example, this was an anxious patient. So they'll ask you this kind of question. Your approach was right, but don't elaborate too much. Just said, I understand your concern. We are trying to figure out what's going on with you. So we'll get back to you. We'll let you know once I'm done with my whole history. Okay. If they're asking you again, just try to be short. Okay, so I'm asking you all the questions to know what's going on. I'll let you know as soon as I'm done, right? Or we might need to keep it short. And then, because you'll find this kind of patients, you'll find patients where they won't want to talk to you, you need to pursue them, like, you need to talk to them, be nice, be patient. So in real life also, you'll find these kind of cases in your family practice, like different patients have different background, someone doesn't want to talk to you. So yeah, you did the right thing, but try to work on your wordings or whatever we are sharing here. Like, I understand your concerns. Yeah, but what I felt, you said thank you couple of times. You don't need to thank your patients like so many times. Just you can say, oh, I'm okay, thanks, just move forward once or twice, that's it. Okay. So I think we're done with these two cases, and we try to cover a lot of differentials. I try to like go like little deep into the differentials so that the next time you're studying, that becomes easy for you guys. So do you have any other question regarding your preparation or anything, or anyone? Because we have a couple of people, I think they didn't have any question or anything. So you can feel free. No one's watching you, so you can just turn on your mic and ask me any question, so that like we can discuss, or someone else can be benefited as well. Anyone?
Hi, I have a question.
Yeah.
If a patient comes with chest pain as well as syncope, which one would you focus on?
So
like if they had come with a combination of critical like chief complaints, which one would you focus?
Yeah, so if someone's coming with chest pain and syncope, it feels like they're having some cardiac issues that are driving the syncope, right? Hello? Yeah. So if someone's coming with like syncope and they have chest pain, it feels like this chest pain is driven by some cardiac causes. So you'll have to dig down like the causes that cause chest pain, and also the syncope or dizziness, like aortic stenosis. So I would go further into this kind of differentials. But again, I would ask other questions related to syncope as well, like if it's like vasovagal ones as well or not, like did they have any anxiety issues, any fear, any recent dehydration. Or what you can do, you can ask, there are like some warning signs, right, to differentiate between the cardiac and non-cardiac causes. Like if I'm not wrong, if these are from cardiac, they'll have some warning signs, like for example sweating, then nausea, vomiting, diaphoretic sort of differentials. So you can ask about those to know like if it's central cause driving this syncope, or is the cardiac cause. But if you see chest pain, there's like shortness of breath with it, and they're like working, and then they had this syncope, I would definitely think it's probably aortic stenosis.
Okay, thank you.
Yeah. And anyone else? I think if there is no other question, we will ending the session. But before I end, I have given a post in our group, so we are still waiting to get enrollment in our course. So if anyone's interested, you can send me a message, and if you need more details, I will send you there. So I think it will be a smaller group where we'll be able to like practice and like go system wise, and I will focus on the history and physical exam. So we can, if you guys are interested, you can send me a message to know more details. So and meanwhile, we'll try to conduct more sessions probably in the future. So for those, stay with our group to know more details. So I think good evening, everyone. Have a good night. See you on next sessions.
Thank you so much. I already spoke with Saida about, I'm very interested about your course. I like how you practice. So I will contact with her.
Yeah,
about
sure.
everything.
Yeah, sure. You can contact her as well. So whoever you're comfortable with. So yeah. So see you guys on next session of you guys are practicing and try to find a partner. So yeah, best of luck.
Thank you. Bye.